Okay, class, real quick, let's go through and discuss drugs of abuse and antidotes. And this will be week 12, lecture 2. Lecture 1 for week 12, if you recall, was headache and multiple sclerosis. So when we talk about drugs of abuse and then antidotes, we'll start with some pathomimetics or uppers. These are your stimulants. And as a stimulant, you got to think of that fight or flight of the SANS, sympathetic autonomic nervous system. So it's going to mimic the sympathetic system. With that said, a lot of the patients you will see in the emergency department will show up with some underlying tachycardia and increased blood pressure to the point sometimes where it's a hypertensive urgency or possibly emergency. We differentiate urgency from emergency if you start seeing signs of end organ damage. You can also have hyperthermia with that and tachypnea. They can be huffing and puffing. So you need to be aware of that when they come in. These are pleasure producing. You do get dopamine effects as well. But the big two are going to be cocaine and methamphetamines. MDMA, you do see in bath salts. You do see the bath salts seem to have their time in maybe the early parts, the mid 2000s, early 2010s. It seems like we're not seeing that as much. Methamphetamine we see often. Now, remember with meth, we talked about its propensity to cause coronary vasospasms and temporary angina. And that can also, if you have underlying, you see older people abusing meth as well. If you do have coronary plaques, that has an increased propensity to cause destabilization and rupture. So it's something to keep in mind, but coke as well. So cocaine, this is a stimulant, and it's not directly affecting those adrenergic receptors, but it's inhibiting the reuptake and the presynaptic cleft. So with that said, you have more norepinephrine, which is a stimulant type reaction, heart rate, etc., blood pressure, and dopamine, the same heart rate, blood pressure, but dopamine being a pleasure neurotransmitter. Some things to keep in mind: the hydrochloride salts, you have snorting or injection in the salt forms. The cocaine base form, that is what we refer to as crack. It is much more concentrated. So that made cocaine, which was maybe a rich man's drug in the 80s, what they called blow at the time, that may be something that wasn't always for the masses. It was for the rich and famous a lot of times, but cocaine base came out and they were able to make this concentrated cocaine where they could sell smaller amounts for cheaper money and people could get even a higher high, but half-life was different. There's a lot of things going on to that, but those are your free bases to get it. Half-life is about an hour. Duration of action is very short, which that in and of itself can lead to more and more use and abuse. So cocaine, the adverse effects, the cardiovascular, we talked about that, but the psychiatric complaints, it can lead to depression, agitation, certainly paranoia. Very similar to the schizophrenic psychosis. Think of dopamine, think of our discussion on dopamine side effects, and you have it. You know what you're dealing with there, and that's what you're going to see there. If you're using cocaine, whichever form you're using, with ethanol co-ingesting, you can get a longer acting, and a lot of times people will offset these as stimulant with a depressant, but just know the psychiatric complaints can be worsened with ingestion of alcohol, and that's because it's metabolized into cocaethylene, which is a little bit longer acting. So the more you take, the more profound effect you can potentially get. The convulsions and hyperthermia we mentioned, the agranulocytosis and the skin necrosis. Google levamisole. They use that in the agriculture industry to deworm. It's an antithelmintic is what it is, but you can get some pretty profound agranulocytosis. Remember your granulocytes, monophils, basophils, eosinophils, neutrophils. But look it up and look at the skin necrosis it causes for those who inject it. It's pretty profound. But that is real. Levamisole is used to cut the cocaine. Cocaine can be cut, cocaine cane, it is a C2. This does have a medicinal purpose with a lot of times with rhino type surgery, nose type surgery. So it's not a C2 like heroin, some of your other drugs, methamphetamine, marijuana is considered a C1. But Cocaine actually has pharmaceutical grade product. We used to have these big giant powders we kept under lock and key, of course, where we would make these nasal irrigations for ENT doctors for nasal type procedures in the OR, and it worked very well. But cocaine is interesting because if you remember when we talked about all of our anesthetic, local topical injectable anesthetics, I should say, if you remember, we mentioned that they cause a vasodilatory effect. And that's why we put epinephrine with it, because it keeps the drug around longer and it snuffs off the blood supply. Well, cocaine is the only anesthetic that actually causes constriction. All the others cause dilation. And that constriction is what leads to a lot of detriment and necrosis at the specific level of snorting. So, because you're getting constriction of blood vessels. So keep that in mind. But it's the levamisole where they inject it that causes the hematopoietic problems and the skin necrosis. Now, cocaine point just fell from my head. I forgot. Gosh, I forgot what I was going to say. Oh, the sometimes it will be cut with some other numbing type things or burn because oh yeah, that burns, so it has to be good. Oh, that's numbing, so it has to be good. So there's a lot of tricks to the trade out there to make a product seem like it is better than it is, and I think levamisole plays that role in there as well. So bad stuff. Bad stuff. Methamphetamine. So amphetamines, again, we're increasing activity of catecholine neurotransmitters again by increasing the release of and inhibiting the degradation of the methamphetamine by monoamine oxidase. Remember, when you inhibit monoamine oxidase, you're not going to metabolize those sympathetic neurotransmitters. So that's how amphetamine works. A little bit different mechanism than cocaine, but the end game is the same. But it's made from using ephedrine or pseudoephedrine, so that's very important. It's a reduction type reaction after extraction from those non-prescription cold allergy medications. That's why when you go to buy pseudoephedrine, you have to get it from behind the counter now. What was happening, I like to call it bum rushing, but suppliers or whoever, manufacturers, would go into pharmacies or grocery stores, wherever you had Sudafed nasal decongestants. They'd literally run to the shelf it was on and just have a bag or basket and just with their arm scrape in every product into the bag and just run. You're not going to catch those people. They're gone. So that's why I got moved behind the counter. That is the reason why, all the thefts. And so they had to do something about it. But you're never going to stop the substance abuse. But ephedrine was another one. Those are called mini thins. You could get those over the counter back in my day. We used to sometimes you could get those and you could dissolve them in your coffee. Dumb thing to do. But ephedrine, though, we would take to try to stay awake, to study more. But only thing it does it excite you? It does. Just like Sudafed would, just like caffeine would, but it just doesn't. I don't think it ever helped study, but I had some buddies that swore that it kept them concentrated and they could study better. But they never really helped me. But you could get them at grocery stores. They were called mini thins, and right there in little things. And stay awake. Guess it was the place to Somnunex or whatever it is that has caffeine in it, 100, 200 milligrams of caffeine, probably equivalent to that, equivalent to a cup of coffee, strong cup of coffee. But those are no longer on the market. Why are they not on the market? They're a precursor to that reduction chemistry reaction to make methamphetamine. So it gave someone an excellent precursor to make a substance of abuse. So again, those are completely taken off the market. But none of the stimulants, even if it's ephedrine or caffeine, you can only drink so much coffee in moderation. You get too much, you can start having palpitations and stuff even with those. So even the stuff that we use right now to keep us going, 5-hour energy, right? I like those. I can only drink half of one and then maybe half of one later. If I drink both of them, I get palpitations. So you can see the top side effects just from the stuff that we do have available to us. Not always the best thing, but routes with meth, oral, intranasal, rectal, IV injection, smoking. The immediate rush with meth is only going to last a few minutes. So now how long or how intense it is certainly going to depend on the route. And it all has to do with the higher the levels of dopamine that you have released in the brain, the more profound the effect's going to be. Again, dopamine is that pleasure neurotransmitter. That's what they're going for. That's the whole goal of it. And but when you do use it continually, it can lead to extreme irritability and paranoia. that ties in for the longer that you go with sleep. I have seen these patients before come into the ED, and I'm here to tell you, their paranoia is putting it nicely. They see things, they think you may be their best friend, and you're there to help them, and they see you as the enemy. Wait, you got a gun, you got this. You're gonna. Are you sure you're not an undercover cop? It's just and I've seen that before in the ED. Fortunately for me, I've never had any type. Well, as far as I know, I haven't had friends, but you never know. But I've never experienced it out on the streets, so to speak. But I was kind of I guess you could say, a goody two shoe growing up, and in college, just didn't. Uh, I was a gamer. I was a gamer. We don't do a lot of meth. We drink a lot of Diet Coke. But in the ED, I have seen them, and the paranoia is just, gosh, I can't explain it. You'll see it when you're on rotation, and then when you become a professional. Certainly, discontinuing can lead to depression. That's no different in the cognitive impairment, no energy fatigue. That's no different than when you quit a selective serotonin reuptake inhibitor cold turkey. You can have a profound rebound effect. And because the short life or the half life of these are so short of meth, no doubt it can come on pretty quick. So what do? You go get another fix, and you find yourself in this perpetual cycle of destruction. I don't think anyone wakes up in the morning and says, I want to be a meth head. So when I see people like this, I know they're the butt of a lot of jokes sometimes, but when I see them, I say a little prayer for them, and I see them as a human that I hope they find their way. I'm not that person to help them find their way. I wouldn't even know where to start, but I certainly have empathy for them, and it's not blame. And some of you are going to disagree with what I'm saying, but I think inherently everybody has good in them. So when you see people who abuse drugs, you got to look back at the root cause. There was like people who used to start smoking back in the 70s and 80s, and then you see them now with lung cancer, COPD. There was a time where they took their first puff on a cigarette, and and I just don't think it's the time to cast. I guess as a healthcare professional, I don't care who you are. I'm gonna you're going to get empathy and sympathy, and you all will do the same. Now, some people are self-destructive. Me, I mean, I sometimes eat. I know the metabolic issues I have. There's some things I shouldn't be eating, and I do. So we all have those. But yeah, you'll see these people, and the ones that truly have really, really bad problems, they're going to be cachectic. They're going to be muscle wasted and almost zombie like. But anyway, the adverse reactions, paranoia, you can have brain damage. Remember, with drugs like Adderall, because you've had that. Well, ADH drugs are the same thing as meth. Well, okay, you got a point, but no, they're not. They're extremely monitored, and I know all the prescribers out there. If you go to a pharmacy and you try to get it refilled a day early, I know some of you, my daughters are on ADHD meds. Go try to get it refilled a day or two early. You get a nasty gram from the pharmacy. So, no, I don't. And it's under the care of usually a physician of some of them now with psychiatry type background, because more and more family practice internal medicine are avoiding them and just send them to professionals. So no, they are not one and the same. Do they have the potential for abuse? Absolutely, they do. You bet they do, because you get the same effect. But also remember the methamphetamine compared to the prescription type products. So Adderall is considered an amphetamine, and that's where the discussion comes in. People, and I tell them no, because the way they affect on a receptor, methamphetamine is actually toxic to those receptors. You lose them, and that leads to brain damage. You're not going to get brain damage on your Adderall if you're taking it under the peer review and at the discretion of a provider who's trained in the utilization of the drug. So no, they're not one and the same. When I hear people say that, it ticks me off, because that's just labeling. It's no different than labeling drug addicts. It's not cool. But meth mouth, yeah, we've all heard of meth mouth. That's the dental decay of those who smoke meth. And it is very destructive, and you've probably all seen that. You go to different places, and you'll see it. It's just there. It's easy to pick out, but it doesn't necessarily mean they're actively using meth. But uh, yeah, there's going to be a need for some dental repair that goes along with that. Now, the limits of pseudoephedrine in the state of Texas, we talked about this in the spring. So, business establishments may not sell to a person who makes over-the-counter purchases of one or more products containing ephedrine. Ephedrine's gone, but pseudoephedrine or nor pseudoephedrine within. And we just worry about pseudoephedrine here. That's all we have. But calendar day, more than 3.6 grams. Well, you can read through that. You get it. You get it. You've all probably gone to buy some Sudafed. I usually end up getting just products with phenylephrine because you can still get that without having, it's over the counter, of course, but you don't have to go to the pharmacy or the pharmacist to get it. You can just buy it over the counter at a convenience store, truck stop, Walgreens if you want to. You can pick it up somewhere. But phenylephrine does not work as well, and it leaves a horrible taste in my mouth. But I'm just too lazy to go get some good old fashioned Sudafed, which when it comes to decongestion activity, going back to that conversation, that's going to be your best decongestant is pseudoephedrine. So ecstasy, club drugs. This is MDMA, and it's analogs of amphetamines and methamphetamines. It does have a hallucinogenic effect. Does last a little bit longer than meth, but you feel good. You feel good. You're loving. You're not anxious. You get extreme relaxation, and I'm not sure the mechanism of that because you still get the side effects of methamphetamine and dopamine, anxiety, potential paranoid thinking. You get the symptoms of colon or adrenergic output, the nausea, the chills. So increased heart rate, blood pressure, hypothermia, all that goes on. But it's just interesting though that you actually get that profound positive feeling, a lot of empathy. This is the thing what they used to call, they still call it the club drug, but you can read through the symptoms you get. A big one is the jaw clenching, the teeth and jaw clenching that you'll see, but that's ecstasy. Bath salts, these are cathinones. These are bath salts will work similar to coke, amphetamines through the inhibition of monoamine oxidase, but these were the ones that lead to that zombie type state. Just think you're out of it. It's a pretty big thing again, and it seems like the mid 2000s and then the early 2010s. But yeah, you're going to get that stimulant effect still. And I think the delusions, it seems from what we've seen these in the ED as well, they seem to be more, instead of a paranoia, more delusion type phenomenon and psychosis was going on. But yeah, you're going to get all those effects that we see. In addition to, you can get some hyponatremia. Now, I've always wondered if that's a phenomenon of a syndrome of inappropriate antidiuretic hormone. Is it working up in the hypothalamus at some point because of the hypothermia you can get as well? You can get the hypothermia with all of them as a stimulant, but it just makes me wonder about that. And then the acute liver failure is something else. That's probably due to something it was cut with, somehow some toxic metabolic product of it, but then an increased risk of suicide as well. Now, the hallucinogens, the ones that make you hallucinate, like LSD, psychedelic, this is working on your serotonin receptors. It's a partial agonist of the 5-hydroxytryptophan 2A receptor, right? That's serotonin. But you'll get mood alterations and sleep disturbances and anxiety. But repeated use, again, you're going to get a tolerance with all these drugs, and it's going to be due to down regulation of, in this case, serotonin receptors. But LSD, they always say, I wrote my best music when I was taking LSD. I always like to think of Jimi Hendrix and the Doors, his songs that he would write. I walked down the hall and I knocked on the door, but it's just like these lyrics that it's like, where did that come from? But yeah, he must have been high on LSD when he wrote that. So you'd see that a lot of times, or at least there was some prejudice in regards of labeling people as LSD users back in, I guess, the 60s, the hippie days. But I don't think I've ever seen anyone who's come in on LSD tripping out, as they would say. That's one that I don't think if I did, I didn't know it. Depressants, this is probably the biggest one. The opioids may be the biggest of the depressants we see, with heroin being specific. But dextromethorphan, yeah, Robitussin DM, right? Suppress your cough. This has at very high doses now. You have to take a copious amount, but It has a depressant effect, even to the point where it can make you stop breathing in some cases. But yeah, you're going to get hyperexcitability. Lethargy is going to follow that. Some ataxia, slurred speech, and nystagmus, mydriasis, a lot of stuff that goes along with it that may not correlate with the depressant effect. But when you get those extremely high doses, you can start getting that dissociative effect. And when I say dissociative, it could be like phencyclidine, PCP, or ketamine. Ketamine, remember, is a dissociative anesthetic type agent where you just dissociate from mind and body. So I always like to say, you give someone ketamine. That's why you have that emergence phenomenon, especially in kids, when you use anesthetic or sedative doses, you dissociate, and when you come back into your being, you have those emergence phenomenons, which can be really scary. I like to say it. You're sitting up in the corner of the room, floating around, watching everything that's going on. Now, I'm exaggerating, but that's how I like to say what I mean or explain what I mean when I say dissociative. Marijuana, everybody knows about marijuana, active ingredient, delta 9 tetrahydrocannabinol, the THC. But the CBD, that's the big thing right now. It comes from the same plant and give you the same effects, but without the high. And it's usually marijuana is usually smoked. I know there's edibles, so on and so forth, but usually the effects begin immediately after the drug enters the brain. It can last 1 to 3 hours. Food will slow absorption if you're taking edibles and prolong the effect. And then, of course, when you smoke it, you get more active ingredient into the bloodstream versus an edible, if you will. Uh, Marijuana users, well, I'm going to say abusers because these are the abusers that show into the ED that chronically use marijuana all the time. We've seen them, especially back when I lived in Colorado before it was legal. They had decriminalized it there, but it wasn't legal in Colorado at that time. But we would see at least once or twice a week chronic users just always smoking pot or eating, whatever the hell they took it. And they would show up with cannabis-induced emesis. And many times it would go on, and they would show up. One of the ways that you could stop it if it occurred was taking a very hot shower. So sometimes you'd see them show up and their skin was kind of red because they just got out of a hot shower. I guess they ran out of hot water. But they would come in and it was just uncontrolled retching once they were done vomiting. But it can last a few hours, it can last a few days, and it doesn't respond very well to antiemetics. What did seem to work was using icy hot cream on their chest, on their back, on their torso, on their sides. That tended to give them relief. And then haloperidol, oddly enough, tended to seem to give relief. But that was due to, that's why I say not just recreational use, someone getting high every now and again, you're not going to have that phenomenon. But just keep that in mind if someone comes in and you can't find a reason why they're with more and more marijuana use becoming mainstream, if you will. That may be something you want to discuss with the patient. By chance, do you smoke marijuana? And if you do, how much do you smoke and or take in? And if it's all the time, you might be dealing with a cannabis-induced emesis, and it's real, and it's going to be frustrating to you because they're going to take up a bed in your ED, and there's not much you can really do for it. But the effects, euphoric, sensory intensification, increased appetite, we've all seen the munchie jokes. Apathy, there can be some hallucinations, dry mouth, possibly some anxiety, fear, distrust, but I don't know. That's not something, I just don't really tie that to marijuana. Acutely, though, you can have the effects of alcohol. You can have a sedative effect and decrease reactivity if you're driving or an inability to perform more complex tasks. You're having some disinhibition. And then from an endocrine effect, you can have some decreased testosterone. Males, it can decrease the amount of sperm being created, so maybe some issues with getting pregnant, and then in women some amenorrhea. So you can see there can be some birthing roadblocks there, if you will. You can get a motivational syndrome. This is going to correspond with apathy, a sense of dullness, poor judgment, certainly decreased concentration and memory loss. Y'all have seen you've seen the Cheech and Chong and things like that. You've seen there are those movies where you have the proverbial stoner, if you will. So, but just a general reduction in goal-directed behavior. You just kind of, I just want to sit around, smoke pot all day. Those may be the ones too that show up and have more propensity to have the cannabis-induced emesis. So, marijuana, some medicinal uses though. There are some unproven. It's all anecdotal at this point. Effects on chemo-induced nausea and vomiting, cachexia to cancer and AIDS, epilepsy, chronic pain, multiple sclerosis, glaucoma, and anxiety. Now, there is a pharmaceutical product called Marinol. It's a prescription THC product that has been used to treat emesis and stimulate appetite in those who have cachexia, a lot of times due to cancer or AIDS. But I'm not going to get into the debate whether you can or cannot use this. I'm just telling you what it's used for sometimes, whether it's so medicinal marijuana versus none, but in the context of what we do in medicine, it's evidence-based medicine with decisions usually based on phase 3 randomized controlled trials, not anecdotes or cadres or cohorts. So yeah, you could come to me with a bunch of stuff that says, hey, it works for this, and I'm not going to say it does or doesn't. In the context of a phase 3 randomized controlled trial, the answer would be no. But I'm not saying it doesn't work. And I'm not saying if I had one of these problems, I'm not saying I wouldn't try it either. So, but I don't have that. I don't recommend it because it doesn't have the studies. But if someone was to use it, I'm certainly not going to pass judgment on them. I guess that's what I'm trying to say. So it could be you. You're going to see it. You're going to see it. It's out there. Ethanol, this is affecting gamma aminobutyric acids. You're enhancing it. Remember, glutamate is your more of your excitatory neurotransmitter, dopamine, etc. Well, GABA is going to kind of help you chill. Also affecting levels of serotonin and dopamine. But anytime you use ethanol with other CNS depressants, you can perpetuate or have synergy with your inhibitions being decreased and then that drunken behavior. But general CNS depressant at high doses, usually not one beer, and it can result in respiratory depression and death. But you know the deal, the kinetics. One thing I will add though with ethanol is with cirrhosis, you can, or liver disease, maybe not to cirrhosis, even a few drinks a week are not. They used to say a glass of wine a day is healthy for you. This thing there's more and more literature coming out. Again, like I said with marijuana, I think there's some proof of concept studies coming out that say we need to look at this further. But even maybe a glass of wine or just a couple of beers a day, they say that's usually good, where they're finding out that that's not necessarily good for the liver over long term. And then binge drinking among college students seems they think, oh, I'm not an alcoholic, I'm not that. Well, if a couple of times a week you drink huge amounts of alcohol, or even one night a week, you're still bombarding your liver with metabolites taking a different pathway because they've lost their alcohol dehydrogenase pathway, and you're getting the metabolites of it, and you're getting liver destruction. So just something to keep in mind with your patients. If you're dealing with college students, yeah, they're going to be out drinking, but I only drink when I go out and party. That's fine. Be safe, be responsible, designated driver, everything, do what you do. But if they're talking about getting drunk and falling down drunk, okay, yeah, your friends are there to pick you up off the floor and post the video on TikTok, sure. But my concern is you're doing pretty profound damage to your liver. And then you take some Tylenol with that and you start getting a cumulative effect because you're taking that to prevent the headache tomorrow morning. So just keep that in mind, that ethanol use it's not as benign as we make it out to be at times with just the casual drinker. It can still potentially have, and there's a lot that goes into it. Your genetics, your makeup, your metabolic pathways, a lot goes into that. And so it's something to keep in mind and appreciate. But there's your chronic abuse. Certainly the hepatic issues is our biggest concern. Now, when you have a sudden cessation and you're a heavy drinker, this can lead to alcohol withdrawals. And if you're in the hospital, we do CWA protocols. We like to use phenobarbital for it because it has a couple of different mechanisms. But how that works is when you take a depressant, is this where you're at? And you take a depressant and you keep yourself down at this level, your body's going to do everything it can to get you back up to this level, okay? But it's going to have to do that by increasing excitatory neurotransmitters or receptors for specific neurotransmitters. So it gets you up to here, but right here, let's say you had 10 excitatory neurotransmitters. And now to get you back up to here, because you're taking the depressant, you got to have 20. So to keep you down here at this level you're at, you drink a little bit more and you end up with 30 just to keep you at that halfway level. That's why you can see functional alcoholics sometimes. It's like, man, they drink a lot of beer and they're not even drunk. It's some other compensatory things going on. They still have the disinhibition. But anyway, when you stop cold turkey, you have all those, you don't have the depressant effects of the alcohol, but you have the stimulant effect of everything else in your body. Instead of innervating 10 receptors, now it's innervating 30, and you get excitation. And that can lead to profound tachycardia and agitation, anxiety. The big one is you can potentially have convulsions and death. So we use benzodiazepines as a drug of choice for that. We like to use the razepam. We have one called Librium, chloride azapoxide we'll use orally, but a lot of times in the ICU, we'll use phenobarbital. We'll use a barbiturate because it tends to work a little bit better. But those of you working in the ICUs or in the hospitals that see that, most of them will have a CWA protocol, and it will define what level of withdrawal you're having, and it'll give you orders to go with it. You'll just say, the nurse may tell you, or you may see it in the history, patient has a history, a recent history of ethanol abuse, drinks a fifth of whiskey a day or 6 beers a day. You're probably going to go, that doesn't mean they're going to have withdrawal from 6 beers a day, but they could. You're just going to say start the CWA protocol. The 6 beers per day probably isn't going to cause a profound issue. So they just need a little Librium to take the edge off, where a fifth of whiskey could lead to maybe the life-threatening convulsions. But just understand the process of that. When you cold turkey stop something, your body's trying to upregulate to keep you up here at this normal level, this first line that I drew. So just appreciate that. Ethanol drug interactions. We talked about metronidazole. I teach you this. There's a drug called Antabuse. The generic is disulfiram, that blocks the oxidation of acetaldehyde to acetic acid. And by doing this, it's inhibiting aldehyde dehydrogenase. And then it's the accumulation of, it's alcohol dehydrogenase, not just, so it's an aldehyde, but accumulation of acetaldehyde in the blood causing flushing, tachycardia, hyperventilation, and nausea. So that's what you're getting, is that acetaldehyde accumulation. Well, that's going to be what they call the disulfiram reaction. Now, we give Antabuse to alcoholics to be a preventative reason to discourage alcohol intake, but I can tell you the amounts of alcohol needed to cause this. This is pretty much a medical myth. I still tell people, because it's out there, that you really need to avoid alcohol, even in mouthwashes. That's what we're taught. If you see it on a test question on your pants, I'm not going to throw this out there. Even if you see it on my test question, go ahead and put that if you take ethanol with metronidazole, there is that risk of a disulfiram reaction. But just appreciate the fact that I don't think that's very real. And that's what recent literature, the risk is there, but it's extremely small. But when I was in school, we were taught even mouthwashes that contain alcohol can make you extremely deathly ill, vomiting and all kinds of stuff. Ethanol, the naltrexone, which is indicated for alcohol dependence, this blocks effects of endogenous alkaloids, but it attenuates, how we use it in alcoholism is it attenuates the reinforcing effects of alcohol. So the patient doesn't feel as intoxicated and there's fewer cravings. And well, is there really a reason for me to even drink this? So something to keep in mind. But disulfiram is one thing we could use, Antabuse. So antidotes, this is very important. Tylenol poisoning, you need to know when someone has an acetaminophen overdose, acetaminophen, APAP is the abbreviation. We give N-acetylcysteine. This is referred to as NAC. You can give it orally. You can put it down in NG tube. It smells like sulfur. It has a very bad smell. Or you can give it IV. It's called acetadote. But regardless of how you do it, when you give acetaminophen, the thing about acetaminophen is when a patient overdoses, they'll actually feel very, very sick. And as you see the curve going up, that corresponds to the patient feeling worse. But then 24 to 72 hours, 48 hours, they feel better. Okay, I'm okay. But then this is when the liver damage is really going on and you don't come back down from this. So when someone overdoses on Tylenol, you got to get them. You got to get them in a pretty quick window. So that's not something you dilly dally around with, because the effect is going to get you a little bit later. It's all short term, but it's as I like to call with suicide in many cases, it's a long term solution to a short term problem. And acetaminophen can be one, even if it's just a cry for help that you can't turn back from. But we usually limit the max daily dose to 4 grams per day. Some experts will say 3 grams per day long term. I'm going to go with the 3 grams per day if it's acutely and you want to get in the hospital or someone's at home. But it doesn't take a lot to start seeing toxicities, so you need to appreciate. But acetaminophen is metabolized into NAPQI, and this is important because it's normally sulfonated with glutathione. But when you take too much, you deplete your stores of glutathione and you have to replace it. And that's where NAC comes into play, because NAC is a precursor to glutathione. So that's why once you use up your stores, everything else is becoming a toxic metabolite. So anyway, the body doesn't have an adequate amount of glutathione for overdose situations. So you're changing the metabolic process to a toxic agent. So the NAC acts as a glutathione precursor, and this allows non-toxic metabolism of acetaminophen. So you can give it IV or oral. Just keep that in mind. There is a nomogram. I do the 2-bag system. It's just how we dose it. But you can go through it. You'll have, if you think you have acetaminophen dosing, usually you can just tell the nurse to start the acetaminophen protocol. I would appreciate the dose of it, and you can find it on these acute acetaminophen poisoning in adults. You certainly can reach out to poison control if you needed to, but just keep in mind when we do the treatment, you always want to make sure that you secure an airway and breathing circulation is necessary. Just make sure everything's good. Most of the time it is, right? Because you're not really getting a sedative effect. But sometimes there may be other medications taken in addition to acetaminophen. But you can give, if a patient is presenting with the drug within 3 to 4 hours of ingesting it, unless there's a contraindication, of course. But you can give activated charcoal. We'll give 50 grams. It comes in a little tube. That helps bind it where you just poop it out. And then, of course, when you get the nap, this is going to be on your serum acetaminophen levels. You're going to want to check those for sure. And you'll continue to check them. If you can't get an acetaminophen level and you think that this is an overdose, just go ahead and give the NAC, and because it's just something you need to do. But anytime, if you can get the level though, and you got a level that's greater than 10, I would be thinking about doing something. That'll be 66. If you're doing it in moles, if you're doing it in a concentration 10, it'd be micrograms per mil. If you're doing it in moles, it's going to be like 65 or 66. And it's right there. It's right there. But read through this. Please read through this at least one time. Just humor me and understand, okay, how much do you give? What do you give? When do you give it? Just please, 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 for both the oral and the IV. The oral, the pharmacy will mix it up for you. Usually give it down an NG tube. It's hard to choke down. I have tasted it before. And the smell of it is a sulfur smell. If you've ever been to the hot springs in Pagosa Springs, Colorado, take that sulfonated smell and multiply it by 100, and that's what you get. It's pretty rank. You can mix it with stuff if you want, but that's when the IV came out. It's called Antidote. That changed everything. It changed how we did it, because it gave us an opportunity. But it's very, very expensive. So, but I think now it's not overly expensive, and we see it more and more. I do the 2-bag system. If you don't know what I'm talking about, you can do that. But if you're having some vomiting, I would recommend an ondansetron type drug. Those are going to be your serotonin antagonist, or metoclopramide. They tend to work a little better than Phenergan type products. I don't like to see people who are already having issues. I want them to be able to interact with me, and Phenergan seems to knock them out some more, cause more CNS depressant effects. And I don't necessarily want that going on, but read through that and appreciate it. So methanol or ethylene glycol intoxication, we see this, and it's due to drinking antifreeze to try to commit suicide, or ethylene glycol methanol. Animals will get into it, your pet, and they drink it, and the toxicity is the same. But when we talk about methanol, a lot of times alcoholics, if they can't get a hold of ethanol, will drink methanol. And you see this sometimes on the head of moonshining. And in essence, it's metabolized to formaldehyde, then formic acid, and that can lead to blindness, renal failure, respiratory depression. So, how do we reverse methanol poisoning? You can use fomepizole, but before we had fomepizole, we would actually give alcohol to as an antidote, and we do alcohol drips for methanol poisoning, and we do that. But anyway, the ethylene glycol, that again is your antifreeze. This is metabolized to oxalic acid, and again, this can lead to renal failure and brain damage. But both metabolic processes are driven by alcohol dehydrogenase. And the fomepizole, in essence, inhibits that pathway. We would give alcohol to get the alcohol to bind up all this so we could go through other metabolic processes and not get the formic acid and the oxalic acid. But when you give something that blocks a pathway, it requires a different pathway, metabolic pathway, to break it down and get rid of it. Sometimes, though, if your anion gap is too high and there's a lot going on, you may require hemodialysis, so you need to appreciate that. But before we had fomepizole, antizole, we would use ethanol drips to IV ethanol to counteract or be the antidote to methanol or ethylene glycol intoxication. You'll see it. And then here's a rapid overview. Again, I would encourage you to read through this. Telling you to can't make you, but same, but keep that in mind and just look at what we do and what we're looking at. Even to the point, when do you need hemodialysis to pull some of this off? So just keep it in mind. Organophosphates and nerve gases we've talked about. Your biggest thing there is going to be cholinergic crisis, so you want to give an anticholinergic for sure. That would be atropine. We like to give atropine because it crosses the blood-brain barrier. Glycopyrrolate does not. But these are going to be your organophosphate insecticides and some nerve gases like sarin. You might have heard about that when all the anthrax being mailed and anthrax powder being mailed to special people. I don't know, you hear about that. But anyway, typically when we see this, it's an insecticide poisoning is what we use it for in fields or agriculture, right? And it inhibits acetylcholinesterase, and that's what you're getting. So you get anticholinergic effects, mydrias, fasciculations, muscle weakness, hypertension. You can get muscarinic effects as well, bradycardia, diarrhea, meiosis, bronchorrhea, mesis. So kind of 2 and 1 going on when you see it. But the big one are going to be when you inhibit acetylcholinesterase, you get more cholinergic activity. That's when you're going to start seeing the Brady down, the diuresis, the bronchorrhea. You have a lot of secretions, a lot of salivation, and you can, in essence, drown to death. Your lower sphincter tone, lower esophageal sphincter tone is going to break down on you. You're not going to have mydriasis. You're going to have this. I think this should say cholinergic effects, actually, because and you'd have meiosis and fasciculations, things like that. That's what's going on. But commonly given together, we give the atropine to block the cholinergic crisis, right? Effects of acetylcholine at the nerve junction. And that's going to combat the bradycardia that you're seeing. That's going to combat the emesis and the diarrhea, etc. So keep that in mind. And then the pralidoxime, that's going to reactivate your acetylcholinesterase so you can begin to break down acetylcholine. So we're going to have to get acetylcholineses flowing again so you don't have excess acetylcholine, but the excess acetylcholine you have, we need to block it with atropine. So remember your cholinergic crisis. You need to remember the acronym BAD sludge. We're still talking about that even in the second semester. And here gives you an idea, a schematic on how to handle an organophosphate poisoning. Again, this is going to be in the context a lot of times with agriculture, the agriculture industry, those who farm land, crop dusters, whatever it may be. The opioids, for opioids, we use Narcan. For most places, you can get it over the counter, the generics, naloxone. Prescription opioid prescriptions used all the time, right? You have your morphine, oxycodone, fentanyl, hydrocodone. Now we have the non-prescription, the heroin, the opium, and we have the opioid epidemic, endemic now, crisis. So This is where your Narcan can come into play. But again, the classic signs is going to be a decreased mental status, respiratory rate of less than 12, maybe none. Your pinpoint pupils sometimes, and then of course, if you want to reverse it, you can give naloxone. It says here IM, IV, or sub-Q. You can give it intranasally, IN or intranasally. That is what they have on the market right now. And I believe it is over the counter. But anyway, 0.4 to 2 milligrams initially, and you can repeat it every 2 to 3 minutes. We talked about this in the pain lecture though, so we got more details. So I won't belabor the point, but that's what we use. When we talked about benzodiazepines, remember we talked about a drug called Romazicon. The generic name is flumazenil. This will reverse benzodiazepines, and in essence, it raises the level of inhibitory neurotransmitters in the brain. And what is the inhibitory neurotransmitter? Or blocking the neurotransmitter levels of or GABA, your inhibitory is what we're affecting. So classic signs, slurred speech, ataxia, depressed mental status, that's what you're going to see in a benzodiazepine overdose. And again, when you give a benzo at the end game, regardless of the channel, it's where the benzodiazepine receptors, and whether it's the 1 or the 2, is it for insomnia, you're using it for, is it for this, that's getting into Ambien. Remember, this isn't going to reverse Ambien, but in essence, what you're doing when you take benzos, you're raising the level of those inhibitory neurotransmitters. Well, the 1, GABA, gamma-aminobutyric acid, and flumazenil, that's what we give when we get into an overdose state. And you're out of it, some decreased breathing, shallow breathing, and death. So flumazenil, Romazicon is your go-to. You don't see that one as much as you'll see naloxone. Usually it's a little bit easier to get yourself in trouble. You can get yourself in trouble with both of them, so I'm not even going to say that. But you'll see more use of Narcan, naloxone. So that ends. One thing we didn't talk about, that wasn't on there, I just realized, and we are going to discuss it. Depending on where you work, when I worked in Northern Colorado at the University of Colorado Health, we used to have a thing called film. We don't really have that now. But film has a lot of cyanide. And when you think about cyanide poisoning, a lot of times we think of a fire, mattresses, and you can get cyanide poisoning through inhalation, absorption through the skin. There's multiple ways to get it. It's not so the exposure can be just inhaling smoke in a fire or getting a lot of soot on your skin. You can get cyanide poisoning. And there's also a drug, if you remember, we talked about sodium nitroprusside, and that at too high of doses, or those who have a normal dose but they have renal dysfunction, can end up with cyanide toxicities. So we used to use nitro poppers and different things, but there's a bottle you can get, one bottle. It's hydroxycobalamin. It is a precursor to vitamin B12, and it's called Cyanokit. It's probably 100, 200 ml bottle. But what you need to appreciate from it is sometimes, depending on where it's at, you'll see they'll have it on EMS trucks, on fire trucks. A lot of times they'll have it. But you need to appreciate, when it comes to toxicology, what cyanide poisoning can do for you. So the hydroxycobalamin in a cyanokit is just one drug now. It used to be several we had to give: sodium thiocyanate, nitro poppers, a lot was going on. But if that patient comes in, and that's why we had it stocked at UC Health in FOCO and Lovington. I'm sorry, Loveland. I'm thinking of Lovington, New Mexico. Loveland, FOCO area, the Northern Colorado area of UC Health that I was over. We had it on our fire trucks because we had the Kodak plant there, and every now and again someone would have some toxicities. But I've seen it used several times due to fires. That's a big one. If you have a lot of people come into the ED, they have burns. If you see soot around the mouth, you got to think of cyanide poisoning, and you got to intervene. The drug overall, though, it's very benign, but it's called hydroxycobalamin. So it's a vitamin B12A. It's a precursor to cyanocobalamin, which is just vitamin B12. But anyway, your cyanocobalamin, it acts as a coenzyme for various metabolic functions. You all know that, including fat, carbohydrate metabolism, protein synthesis, cell replication, megablastic anemia. So, certainly has an effect in the hematopoietic system, right? But in the presence of cyanide, this hydroxycobalamin molecule can bind, it's either one or two cyanide ions, but it binds that cyanide ion and displacing it from a hydroxyl. So the hydroxycobalamin, it's displacing it from a hydroxyl ligand, if you will. And this is linked to a specific ion. Can't remember, maybe cobalt, can't remember quite often. But anyway, it forms cyanocobalamin, which is then just excreted in the urine. So it makes it very, very nice. But you may see this. This is something you need to know. I'm surprised it wasn't in this lecture. I didn't build this lecture. A colleague built this one for me. But we don't really worry about the side effects necessarily because this is going to be a life-threatening situation. I've been involved in giving the cyano kit maybe less than 10 times. I'm going to say less than 10 times. So I believe you can have some discoloration of the urine to a reddish color. I'm not sure. I've never stayed long. They usually, when I saw them, they were in the emergency department. They were either transferred to a higher level of acuity. But the urine discoloration, well, I take that back. It's going to be 100%. It's going to be 100% because of the fact that it is cyanocobalamin. Now, when you do have urine discoloration with these types of drugs, sometimes it can last a few weeks. So I want to encourage you to educate a patient. But no, if someone comes in and you think they had cyanide poisoning, they're not going home tomorrow. You're going to have it pretty bad. But the last time I used it, I was in a house fire situation, and actually all the family members, they had soot on them and had showing some signs of cyanide poisoning, and it was just safer to give every one of them the 5 gram dose. And I think it is an actual 5 gram dose. Not sure, but anyway, that's going to be protocolized for you as well in an ED. But do understand it, do appreciate it, and understand what we're doing in these cases for these patients because it is very bad. But anyway, I'm trying to think of anything else you need to know. You need to give it, we give it over, I'm going to say 10 to 15 minutes when we give it. I think it needs to be 15 though, because you can get some infusion related issues with it. So just keep it in mind. But we'll give 5 to 10 grams. You can give a couple of doses if you need be, but just keep it in mind. I think it can be another place. Vitamin B12. The cyano kit can actually be used if you're not familiar with vasoplegic syndrome. That's another one. That's something that comes out usually in your patients that are post-op open heart. Now that we're not going to test you on that now. But these are patients who, because we just recently did this on a patient, we were using it, but this is going to be in a patient who typically they don't respond to methylene blue. Other things, serotonin syndrome, glucose 6. There's a lot that goes into. I'm not getting into details, but I want you to have the full picture, the full Monty. So that's another place you might see cyano kit used. But for our discussion, cyanide poisoning. So I'm glad I remembered to bring that up. I don't know what made me think of that, but I'm glad I did. So please keep that in mind. Anyway, that ends. That is week 12, lecture 2. And we'll jump back into, I think we're heading into dermatological lectures for lecture 3 for this week. So appreciate your time.